Last night on Checkpoint, we brought you the story of the shortage of ICU beds at Dunedin Hospital in the southern DHB, an area covering all of Otago and Southland. We spoke to three families, all of whom had experienced delays as they lost the beds, thanks to the absence of availability of post-operative care in the ICU unit. We spoke to the DHB's CEO, Chris Fleming, who said they don't have enough ICU beds, but they are getting more. But he was unable to say whether any patients had died during the period after cancellations and before rescheduled surgery could occur. One family strongly believed their father had indeed died in such circumstances. Dr. Nigel Miller is the Southern DHB's Chief Medical Officer. I asked him about the case of Owen Glover.
I've made contact with the next of kin we have listed, one of his family members. And of course our primary responsibility is to respond to them and talk with them. So we'll be setting up a meeting in the near future, I would hope next week, if we can do it, to go through matters and hear their perspective and, of course, give them any information they feel they need.
Right. So obviously you want to talk to the family before you talk to RNZ's audience. But in brief, did he die waiting?
I think my primary responsibility is to speak to the family in order that we can fully understand their perspective and they have all the information they need.
Yeah, the perspective is on the record, though, isn't it, that he had appointments postponed in February, March, April and July, and he died in August.
Yeah, that's what I heard on your program yesterday.
And is that a statement of fact?
As I said, my primary responsibility in the first instance would be to speak to the family in order that they have all the necessary information.
Okay. We also had on yesterday, and I think we can talk to this because this is the universal in the particular, Kelly Gibbs, whose daughter, 13-year-old daughter, Amber, who's severely disabled, was having surgery for scoliosis. Now, that was postponed because of an absence of ICU beds. And the family had come from far and wide. Grandparents had taken time off work, everyone was there, and she was stood down at the last moment, not because the surgical team wasn't ready to go, but because the ICU beds weren't ready for her after the operation. Is that a satisfactory state of affairs?
Absolutely not. And that's an awful thing to happen. And we sincerely regret finding ourselves in that position of not being able to meet their reasonable expectations of the surgery taking place. I absolutely agree with you on that. It's not where we want to be at all.
How often is that sort of thing happening?
It has been happening more often of late, and I think that's an unsatisfactory situation, I think, as we discussed yesterday, or discussed with you yesterday.
Yeah, with Chris Fleming, yep.
And so we're in a really difficult place. One of the challenges for New Zealand is the small size of the hospitals means you have a lot of variation in the need for ICU capacity. So it goes up and down a lot more than we'd do in a larger place because it smooths out with a larger size. So that's a real challenge. And then our clinicians are faced with this really difficult challenge, the difficult problem of, do you select the patient with cancer? Do you select the patient with scoliosis? Do you select the patient with cardiac problems? Each of which is going to suffer some significant disadvantage and potentially some harm if you don't do it straight away.
And that dreadful process, that selection process, which, as you say, must be nightmarishly difficult for your surgical teams, your physicians, would be mitigated and made easier if you had more ICU beds, wouldn't it? I mean, it's a statement of fact, isn't it?
Oh, well, it would never go away. I mean, unless you had an extremely large ICU most of the time, which had a big chunk unused. So we've got to solve this, John. I mean, you can agree with that, I presume.
I couldn't agree more, and I think everyone we have spoken to would agree with you.
So it's something we're actively pursuing. We met with the cardiac team and the ICU team last week to look at this very issue of how we can make better progress on it.
Have you postponed cardiac surgery today, heart surgery today, because there weren't ICU beds for the patients after the surgery?
I understand there have been cancellations today, yes. So
how many cancellations today?
Today, I understand it was 2 cases.
And so, can we talk to the details of that? The heart team, and you have a very good heart team in Dunedin, was ready to go.
Absolutely, yes.
And so the only thing that prevented them from going was an absence of ICU beds for post-operative care.
That's exactly correct.
So what does the heart team do when they're stood down because of the absence of ICU beds for post-operative care?
Well, the heart team are then naturally disappointed and frustrated.
And wasted, presumably.
They make it very clearly known what the difficulty is. They communicate it well. and I've got great respect for them as professionals.
Right. So are they on the record with a sense of frustration about this?
Pardon?
Are they on the record to you with a sense of frustration about this?
As I said, we met with them last week, talked it through in detail, and because we don't doubt it's an important issue. So what I'm trying to get through is how do we find solutions? What are the ways we go to resolve this?
Okay, and we talked about those with Chris Fleming yesterday, and he's going to increase the number of ICU beds. Well, sorry, not he is, but the hospital is. Can I ask you what the heart team do when they can't operate, as was the case today, because there are no ICU beds available? What have they spent the rest of their day doing?
I haven't checked up on exactly what they're doing. They're professionals, and they always have a considerable amount of work to do.
But they're surgeons, aren't they?
They've been wasting their time.
They're surgeons who aren't able to operate because there are no ICU beds.
Yeah, well, surgeons have lots of things to do apart from operating. So they wouldn't be doing nothing. They'd be much better operating and much happier operating. I'd agree with that.
How is this resolved so that your surgeons can do surgery, the people who need the surgery can get it, and you can provide the ICU care, the bed numbers, to stop what someone was calling a kind of constipation?
Well, as I said, I think was said to you yesterday, that we have got capabilities probably to increase the beds in the short term. We are completely rebuilding the unit. It's actually happening now. So it's actually started to finish next year. Now that doesn't give us a large increase in beds in the beginning, but it changes our flexibility because we'll have 8 ICU beds and 10 HDU beds, high density unit beds, in the same unit, with some flexibility between them, so we can move. We can decrease the HDU beds, increase the ICU beds if necessary. That new unit will be quite transforming because our current unit, the history of Dunedin Hospital and how we've been struggling to get it resolved. It's small, cramped, difficult for people to work in, and we owe our staff better than that. So that's the new unit will work much better, and I expect that the patient flow will go much better. That'll give us an extra resource. We can, of course, arrange to have some surgery carried out in the local private hospital, which is what we're doing. We can ask other district health boards, so that doesn't tend to work very well because it's difficult for patients and families, and also difficult for other district health boards who have their priorities. We could transfer patients out of ICU to other district health boards, but that would only end up bumping somebody else's cardiac surgery somewhere else. The ICU units at the moment in the South Island, at least, are under quite a lot of pressure. It's not just our unit alone.
And there is a spillover from that, isn't there? Can you, for example, confirm that there's been a patient who spent more than 12 hours in the emergency department today because there was no ICU bed available? So there's a kind of dominoes falling from ICU to emergency.
It causes difficulties in various places. And, sometimes we would choose to manage a patient in the emergency department rather than ICU in order so they can go straight from ED to the ward. That's a useful thing to do sometimes.
And so that is happening. Was that happening today as a result of ICU being full?
I don't know about today. We have done that in the past, and that's not necessarily a bad thing. That might be a constructive way to manage a patient in the short term. So there are lots of complications when any part of your hospital flow system is suffering difficulties.
Miller, Dr. Nigel Miller, who was the Chief Operating Officer, Medical Officer at the Southern DHB.